Second case, a young lady, positive family history of HCM, and the patient came presenting with chest pain or chest discomfort. The patient received an echo that revealed asymmetrical myocardial thickening, more at the basal, and hypertrophied papillary muscles. ECG revealed some abnormal ectopy and incomplete right bundle branch block. I'm sorry I don't have videos for the echo, but those are static images as a kind of 4-chamber view, or we could see some hypertrophy in the basal septum. So this is the left atrium and left ventricle. And on the Doppler, so this is a kind of a 3-chamber view, there is mitral regurgitation, so the left ventricle, left atrium, and the outflow tract. There is mitral regurgitation in the Doppler and the echo. And her ECG, as we mentioned, there was no abnormal Q waves, or there was no abnormal QRS, P waves, sinus rhythm. And I think this is the description of the incomplete right bundle branch block. MRI was requested among the investigations that was requested for the patient at that time. Short axis cine. I think the function, I think we all would agree that the function is preserved, good functions. There is no dilatation, but it might be that there is some hypertrophy in the basal septum or in the basal anteroseptum. So there is some hypertrophy, and if you may notice that the basal cuts are hyperdynamic compared to the apical region, but overall the function is preserved and good. And the long axis views, so we have the 3-chamber view, 2-chamber view, 4-chamber view. Here's the regurgitation jet that we saw on Doppler in the echo. But again, the function was okay. The function is preserved. Focal hypertrophy of the basal septum. And if you remember that the history said there is a positive history of HCM, but would the audience think that this patient has HCM? So the patient didn't have HCM, as a matter of fact, but let's discuss the images on static views. But before going to the static views, this is the late enhancement. So we have the short axis, 4-chamber and 3-chamber. Might be that there is mild enhancement here at the basal, at the mitral area or the mitral annulus. If we move to the short axis of the late gadolinium enhancement, it might be clearer. So there is a mid-wall enhancement, basal infralateral. And on the static images, so the patient had, this is 2-chamber view, left atrium, left ventricle. Yes, there is some hypertrophy in the basal, and the basal cuts were hyperdynamic compared to the apical segments. But there is a mitral valve prolapse of both leaflets. And here is the jet of the mitral regurgitation. Again, the jet of the mitral regurgitation, as you may see here, is clear the mitral valve prolapse. And secondly, there is a mitral annular disjunction. So this is the mitral annulus, and here is the myocardium, and both of them should be attached, so these should be moving together. But in this case, there was the mitral valve prolapse, some fibrosis at the basal infralateral, as well as the mitral anal disjunction. And this triad is arrhythmogenic. And probably this was the cause of the palpitations or the chest discomfort that the patient was experiencing. And the advice from MRI was Holter monitoring of those patients because this triad is arrhythmogenic. Any questions before we move to the third case?
Assalamu alaikum.
Alaikum.
When would you send this patient in collaboration with the heart team for surgery regarding the mitral annular disjunction?
Well, I think at the moment in literature it's not cleared the mitral annular disjunction and the position of the mitral annular disjunction, but I think recently now there is increased awareness. We have published this paper as a case report, but I found out that while discussing with the cardiologist colleagues that there is no clear guidelines about it in the literature, how to monitor those cases. And it seems that it depends on the degree of the mitral regurgitation, not on the mitral annular disjunction. And I personally changed my practice, so now I check, and you will be surprised that it is present in many cases. It's frequently encountered in MRI, especially if you have connective tissue disease patients like Marfan syndrome, for example. There is a high percent of those patients having the mitral annular disjunction, and they are not being sent for any surgery for the mitral unless there is a significant regurgitation. Then the discussion will be whether to do something about the regurgitation or not.
So I have a question. I have read that there's an association between mitral annulus disjunction and tricuspid annulus disjunction, like 40% in the cases of MAD, there are also associated TED. Do you usually screen for it? Or you pop it in your mind? Or there's no such an association?
Well, I didn't see, so far I didn't see tricuspid annular disjunction. All the cases that I saw so far, I've been collecting the cases since I changed my practice, and I got around 15 or 16 cases so far, but all of them are mitral annular disjunction, but I didn't see tricuspid annular disjunction, so I'm not sure about the percent of the association. Okay. Should I move to the next case? Or?
Yeah, thank you, doctor.